dentist to speak to you about the safe mercury amalgam removal technique. And before we actually get into the protocol, let's just review some things. Most of you probably already know most all of this, but let's just make for sure. Often referred to as silver fillings, which has been very misleading over the years because it just totally ignores the issue. The predominant source or the predominant material is 50% mercury. And it's the elemental type, otherwise known as also inorganic mercury. Most people refer to it that way. Although there is actual vapor that comes off of the mixed material. And as we show here, it's a combination of these elements, the silver, copper, tin, and zinc, which I just want to draw these other ingredients to your attention because actually those can sometimes play mischief with some individuals, depending on their situation. This material also, because of all these mixed metals in the mouth, in the saliva, create kind of a battery effect, or what's known as galvanism. And as it's already been alluded to, that can be tested, with various probe systems. The big question is, are patients that reacting to these fillings, is it more because of the mercury or because of the galvanism, or perhaps both? And generally, the consensus by a lot of biological dentists are that if a patient notices a very quick improvement, like within hours or the same day or day or two, upon having these removed, then that might be a hint that it's more of a galvanism issue. But again, it's really hard to pin down because it could be both. You just don't know for sure. It's when dentists buy amalgam, dentists that are still using it, it now comes in a capsule that's sealed, and on one side is the mercury in a liquid form, the elemental mercury, and the other side is a powder mixture of the elements that I already mentioned. And so in order to turn it into this amalgam material, it has to be mixed, and there's a device called a triturator, which provides the trituration, and it usually about 10 to 20 seconds, it mixes it, and then for a period of time, a few minutes, it will be in a soft form that can be molded into the tooth, but then it quickly hardens, and then it reaches its full strength usually within about a 24-hour period. Okay, come on, there we go. So here is a mouthful of mercury fillings that, fortunately, I don't see this too much, not nearly as much as I used to. Just an indication that the use of amalgam in the United States is decreasing. It's just not fast enough, unfortunately. But it is becoming less frequently used. Some of you already picked one of these up from the booth. We've got the big poster over there at the booth. This came about because a few years ago the IAOMT was approached to contribute a book chapter to an epigenetics textbook. And as part of that project, we developed this infographic to kind of summarize all the information and material. So what I'd like to go through is just a quick summary of the various sections here. And this information is on our website as well. In fact, the whole infographic is on there. But yeah, we acknowledge that the contribution of mercury exposure is, in most people, the vast majority is from the dental amalgam. Certainly, depending on their seafood intake, that's going to play a role as well. And in this section, we talk about the risks from the exposure. There's some interesting data that was generated through some research that was published, it's been about about 6, 7 years. Actually, that was in preparation for an FDA hearing that was held in 2010. And basically what the researcher did was an analysis of the average number of fillings, and there's actually, I don't know if you've heard of NHANES data, but it's government data that's compiled, and it's a treasure trove of data that can guide researchers looking for trends in our population relative to health. So what he did was some calculations, and based on the guidelines of what's so-called safe exposure might be by the EPA, the average person with amalgam fillings, 67 million Americans would exceed these so-called safety levels. And if you're in California, where the EPA standard is less than in the United States, the rate would go to 122 million Americans would exceed the levels. So when anybody argues with you, oh, it's just a little bit, it's not enough to cause a problem, this is what I typically like to throw in their face. Or if they want to argue about the research and studies that really aren't conclusive, it's like, look, we have data that shows these levels are exceeding the safe amount that people should be exposed to. And that's should be recognized as a problem. Unfortunately, our policymakers have not really become aware of this or taken it seriously if they have. So this section kind of illustrates what's going on throughout the body. It all starts here in the mouth with the exposure. It's coming off as a vapor. It's a 24/7 baseline exposure. It's kind of like a roller coaster ride throughout the day. Anytime those fillings are stimulated by anything from toothbrushing to clenching and grinding, chewing, eating a meal, or hot things, beverages and foods, there's going to be an increase for about 60 to 90 minutes. Once the stimulation stops, then it takes about that 60 to 90 minutes to return to baseline, of which there's still that continuous exposure. So one of the worst things for people that are gum chewers, I mean, their level of exposure can be extraordinarily higher than the person that doesn't chew gum and that's not snacking a lot throughout the day. So like I said, it starts in the mouth, and then that vapor that kicks off is going to be inhaled, a certain amount of it inhaled, and the lungs absorb about 80% of that mercury vapor, which then gets into the blood system and circulates. In pregnant women, it can get into the fetus and accumulate there. It does cross through the placenta. And then if they are breastfeeding, the mercury can accumulate in the breast. And this has all been documented in numerous studies over the years. Again, just widely ignored. As just, it's just a little bit. Not enough to cause any harm. It tends to concentrate in kidneys to a certain extent, and some of the research has shown alterations in normal kidney physiology. That's all been documented. One of the things of great concern is the half-life of mercury in the brain. Unfortunately, it's over 20 years. So when you start talking about detox, well, what tissue are we detoxing? And getting it out of the brain, first of all, getting a substance that's going to help with detox, getting it into the brain can be a challenge in some cases. And there's not as much research in that area as we'd certainly like to have for guidance. And the next one is, since this was an epigenetics textbook, we had a little section over here. It's summarized. And you've heard of some of these things, the MTHFR, CPOX, the APO4 that was mentioned yesterday. Folks with those SNPs typically are going to be more challenged when they're exposed to mercury. There's a greater risk that they're just not, if they're not methylating well enough, that they're not making enough glutathione. All these different pathways are going to be interfered with to where then they get themselves into trouble with what we call retention toxicity. And this is a table that just shows a lot of the common health conditions that can be associated with the mercury exposure. Probably most of us are familiar with a lot of these. Quite a few of them are neurodegenerative disorders. The next will be a video I'm going to show. I apologize if you've already seen this. It's from the University of Calgary, where there was a lot of research done back in the late 80s and 90s. I don't know if you've heard of the sheep studies, the monkey studies. Those were just very basic places to start with animals to document what was happening with the mercury. Basically, these mercury fillings were placed in these animals, and they used radioactive mercury. So we knew for sure the source of the mercury. It wasn't in their feed or the air or the water or anything like that. It could be traced back directly to the amalgam. So once all that was established, then they did this research relative to what happened. It's titled How Mercury Causes Brain Neuron Degeneration. It's about a 4-minute video clip here.
How mercury causes brain neuron degeneration. Mercury has long been known to be a potent neurotoxic substance, whether it is inhaled or consumed in the diet as a food contaminant. Over the past 15 years, medical research laboratories have established that dental amalgam tooth fillings are a major contributor to mercury body burden. In 1997, a team of research scientists demonstrated that mercury vapor inhalation by animals produced a molecular lesion in brain protein metabolism, which was similar to a lesion seen in 80% of Alzheimer's diseased brains. Recently completed experiments by scientists at the University of Calgary's Faculty of Medicine now reveal, with direct visual evidence from brain neuron tissue cultures, how mercury ions actually alter the cell membrane structure of developing neurons. To better understand mercury's effect on the brain, let us first illustrate what brain neurons look like and how they grow. In this animation, we see 3 brain neurons growing in a tissue culture, each with a central cell body and numerous neurite processes. At the end of each neurite is a growth cone where structural proteins are assembled to form the cell membrane. 2 principal proteins involved in growth cone function are actin, which is responsible for the pulsating motion seen here, and tubulin, a major structural component of the neurite membrane. During normal cell growth, tubulin molecules link together end-to-end to form microtubules, which surround neurofibrils, another structural protein component of the neuronal axon. Shown here is the neurite of a live neuron isolated from snail brain tissue, displaying linear growth due to growth cone activity. It is important to note that growth cones in all animal species, ranging from snails to humans, have identical structural and behavioral characteristics, and use proteins of virtually identical composition. In this experiment, neurons also isolated from snail brain tissue were grown in culture for several days, after which very low concentrations of mercury were added to the culture medium for 20 minutes. Over the next 30 minutes, the neurite membrane underwent rapid degeneration, leaving behind the denuded neurofibrils seen here. In contrast, other heavy metals added at this same concentration, such as aluminum, lead, cadmium, and manganese, did not produce this effect. To understand how mercury causes this degeneration, let us return to our illustration. As mentioned before, tubulin proteins link together during normal cell growth to form the microtubules which support the neurite structure. When mercury ions are introduced into the culture medium, they infiltrate the cell and bind themselves to newly synthesized tubulin molecules. More specifically, the mercury ions attach themselves to the binding site reserved for guanosine triphosphate, or GTP, on the beta subunit of the affected tubulin molecules. Since bound GTP normally provides the energy which allows tubulin molecules to attach to one another, mercury ions bound to these sites prevent tubulin proteins from linking together. Consequently, the neurite's microtubules begin to disassemble into free tubulin molecules, leaving the neurite stripped of its supporting structure. Ultimately, both the developing neurite and its growth cone collapse, and some denuded neurofibrils form aggregates or tangles, as depicted here. Shown here is a neurite growth cone stained specifically for tubulin and actin, before and after mercury exposure. Note that the mercury has caused disintegration of tubulin microtubule structure. These new findings reveal important visual evidence as to how mercury causes neurodegeneration. More importantly, this study provides the first direct evidence that low-level mercury exposure is indeed a precipitating factor that can initiate this neurodegenerative process within the brain.
So that video is available on the internet. It's very easy to find if you just Google it. But of course, it's in the slide presentation, will be posted on the BRMI's website here for too long. So I want to shift now to what's been going on kind of on a worldwide basis. In the year 2013, after about 5 or 6 years of various conferences around the world, this Minamata Convention on Mercury, which was under the United Nations Environmental Program, was adopted, and at this time about over 100 countries have ratified it. Particularly the United States. Actually, the United States was one of the first, and then Europe has been real strong with this as well. The section, of course, the organized dentistry fought in any kind of inclusion of mentioning dental amalgam in this treaty, but fortunately we were able to lobby, various organizations, including the IAOMT, were able to lobby to get this to stay in the treaty. And there's a lot of watered down language in here, and unfortunately the term phase down was used as opposed to phase out. But the valuable thing about this is it really opened the door for conversations. Like when I've been in touch with a dean of a dental school, I bring this up as part of what's happening in the world, and it kind of gets their attention because this is something official. And even though it doesn't call for a phase down, it's like the writing's on the wall, so to speak. The one thing in Europe, like I said, they're taking it very seriously, and in Europe, starting here in just another month, the dentists are being directed to no longer use mercury fillings in pregnant women and breastfeeding women, as well as not to be used in children under age 15. That's not a total ban like we've been fighting for years, but it's a hell of a lot better than what we've got here in the United States. And unfortunately, the FDA has just really dragged their feet on this. So that's some encouraging news, but despite that, you still see headlines like this. Dental amalgam market trends estimates high demand by 2023. I don't know how they came up with that number, but this is just the other month. I can't remember how I stumbled across it, but it just made me want to throw up. It's like, come on, what is going on here? So we keep struggling and fighting, and a couple of years ago, the IAOMT helped to support and fund a documentary. We mentioned it yesterday, called Evidence of Harm. I think about all the copies have been taken from the booth over there. But I'm going to show you, it's just a short 1-minute trailer that kind of gives you a little flavor and sense of what it's about.
Mercury is one of the most toxic elements.
Silver amalgam fillings, does it contain mercury?
It does.
So when I went to the dentist, and I let him talk me into replacing all of the silver fillings on the right side, and that's when everything started.
These amalgams release mercury vapor, which is well over 100 to 600 times higher than what the ADA estimates.
80% of it that you breathe in collects in your body, and a good portion of it ends up in your brain.
Within a few weeks, I started noticing some weird neurological sensations.
We have to do something that's very dramatic. I am going to visualize the mercury vapor rolling off of these amalgams when you put a drill on them.
After that dental work, I got out of bed one morning and could not walk. And these mercury fillings are the trigger in many cases.
Dental schools ought to be fearful of major lawsuits because this is not a secret anymore.
I've never seen levels of mercury this high.
After 2 decades in the news business, I know the truth, and the truth is silver mercury fillings are causing disease, and they are making people sick, keeping them sick, so help me God.
Why is it that the ADA will not tell the public that mercury amalgam is harmful.
It's even worse than what they imagined.
So, maybe a little sensationalized, but you know, the music and all, but it gets a lot of points across. And as we all know, I think in here, this is a very serious issue. So we keep fighting the good fight, trying to spread the word. This label was, you might have noticed it in the video, and this is a label like if somebody buys amalgam, it's the actual text from an amalgam label. So when you buy this stuff and there's packaging, and the problem is nobody pays attention to this stuff. Hey, you know how it is. Who reads the instructions for your devices that you get? You know, a lot of times we're just going to be throwing that in the trash. So, but there's some very scary warnings in here. And on the next slide here, some of you maybe have heard of safety data sheets. This is something that's mandated by Osha for the workplace environment. And it's to protect employees. They have a right to work in a safe work environment. So when you look through these safety data sheets, you'll find all these different warnings about these hazardous situations. Again, typically ignored. Let's see, there was a lawsuit about 15 years ago, we call it a product liability case, in which one of the major amalgam manufacturers was sued because of product liability, if you want to call it that, or the exposure to the mercury. And it turned out that the manufacturer won the case simply because they showed to the court that they had provided all of these warnings. They had followed the requirements, and it's just that the end user's not paying attention. So it's kind of like, ooh, what does that say? In fact, there's a term called the learned intermediary, which means practitioners that are using things that could be harmful really are obligated to pass that information along to their patients. Of course, we all know that as informed consent. Problem is, the placement of amalgam fillings has been around so long, and has been such an integral part of traditional dentistry, that as a result, it's just it's no big deal. And there's no sense that an informed consent process needs to be done ahead of time, placing an amalgam. So a very frustrating situation. So our regulatory agencies have failed us. The FDA, I mentioned there was a hearing, there was a number of hearings through the early 2000s, and the last one was in 2010. I actually attended it and testified at it, and some of the panel members were very sympathetic to our cause. The problem was that that panel was not charged with making really any kind of final decision. They were just there to provide some advice to the FDA about what to do about this filling material. And the FDA swore that they'd do something, and so a few years goes by, nothing's happened. So the ADA initiated a lawsuit, the IAOMT initiated a lawsuit against them to flush it out and see what's going on. Well, luckily we had an insider also at the FDA. And basically the FDA had prepared a document, which we have on our website, that the recommendation coming out of FDA was going to be not to use amalgam fillings in, kind of like what Europe's doing, pregnant women, people with kidney disease, people with any kind of neurodegenerative disease. But it wasn't the FDA didn't have the authority to really implement that. The higher ups at HHS had that responsibility. And we don't know the details of why, but somehow back in around 2012-ish, that was nixed. That recommendation from FDA was nixed and never saw the light of day until it got on our website. But who comes to our website? Not that many people, unfortunately. So that's been very frustrating. CDC, they all pretty much say the same thing, although we did get a little bit of reprieve from EPA in which they just mandated that all dental general dentists, like an orthodontist, since they're not placing amalgam, they don't need to have these amalgam separators. These are basically filters that are put into the dental office so that as we're dealing with amalgam, either dentists that use it and they're placing it, it goes down their suction and ends up in the sewer or something. It's to prevent all this waste, this mercury waste, from getting into the sewer systems. Because like in Louisville, we call it the Metropolitan Sewer District. Each large city has their agencies that deal with wastewater. And a lot of them were finding that their levels of mercury were above the EPA standards. They're trying to figure out where it's coming from. Over the last couple decades, it's been figured out, a lot of it's coming from dental offices. So there's this huge environmental impact, and that's where we've gotten our foot in the door to some extent as far as getting a little more concerned about mercury. In fact, that Minamata Convention, that came through the United Nations Environmental Program. So the environmentalists have been on this to a certain degree, and that's helped, but it just hasn't closed the deal. For some reason, there just seems to be this mentality that the safest place on earth to store mercury is in amalgam fillings in the mouth. And that's just insane. Let's see, Osha and NIOSH. So I showed you those safety data sheets. Unfortunately, they're not enforcing the various regulations. They have standards for safe levels so that dental workers aren't going to be harmed by any of this exposure. Well, they don't really go into offices. They don't do any kind of inspections to regulate and ensure the safe workspace. We've been working real hard to raise the level of awareness in the dental profession. Again, we're a small group. We've been approaching a few dental schools to try to encourage them to, hey, at least protect your students. Your students are paying you all this money to come here to learn, not to get poisoned, and not to then have that working against them the whole rest of their lives and their dental careers. And of course, the big problem is that even if amalgam placement were banned today, we would still have the issue of a legacy material that's hanging around in people's mouths for many, many years. The only good thing about the material is that it can last 40 or 50 years as far as its physical characteristics. But that just means it's going to be decades before we've eliminated this scourge on our health. The next video is going to be the full SMART protocol. Now, the IAOMT has really had a protocol since its beginning over 30 years ago. It's been tweaked over the years, and here recently, a few years ago, we decided to rebrand it, add some splash and color to it, came up with the logo. We have actually created a new website just for this called thesmartchoice.com, and we've got our Facebook page. We got two, the one for the IAOMT, the other for this protocol.
I'm Dr. Griffin Kall of the International Academy of Oral Medicine and Toxicology. Patients and dentists should make sure that each step of the safe mercury amalgam removal technique, or SMART, will be applied during a dental appointment for filling removal. The first step is for patients to consult with their dentist before the mercury filling removal begins, so that both the patient and dentist agree that all safety measures will be in place. This helps to ensure that the patient and dentist know exactly what to expect. It's also helpful to watch the following example of the safe mercury amalgam removal technique, or SMART, being applied. Each room where mercury fillings are removed should have adequate filtration in place, which requires a high-volume air filtration system such as IQ Air Dental Mercury FlexVac or similar device, capable of removing mercury vapor and amalgam particles generated during the removal of one or more mercury fillings. If possible, windows should be open to reduce the mercury concentration in the air. The patient should be given a slurry of charcoal, chlorella, or similar absorbent to rinse and swallow before the procedure, unless the patient declines or there are other contraindications making this clinically inappropriate. Protective gowns and covers for the dentist, dental personnel, and the patient should be in place. All present in the room should be protected because substantial quantities of particles generated during the procedure will elude collection by suction devices. It has been demonstrated that these particles can be spread from the patient's mouth to the patient's knee and to the chest, shoulder, and neck of the dentist and dental assistant. Either a properly sealed respiratory grade mask rated to capture mercury or a positive pressure, properly sealed mask providing air or oxygen should be worn by the dentist and all dental personnel in the room. Non-latex nitrile gloves should be utilized by the dentist and all dental personnel in the room. Face shields and hair head coverings are to be utilized by the dentist and all dental personnel in the room. In order to protect the patient's skin and clothing, a full-body impermeable barrier should be utilized. External air or oxygen delivered via a nasal mask for the patient also should be utilized to assure the patient does not inhale any mercury vapor or amalgam particulate during the procedure. A nasal cannula is an acceptable alternative for this purpose as long as the patient's nose is completely covered with an impermeable barrier. A saliva ejector should be placed under the dental dam to reduce mercury exposure to the patient. A dental dam that is made with non-latex nitrile material should be placed and properly sealed in the patient's mouth, as well as a full head, face, and neck barrier that is under and around the dam. During amalgam filling removal, the dentist should utilize an IQ-Air dental mercury flex vac or similar device in close proximity to the operating field, that is 2 to 4 inches from the patient's mouth, to mitigate mercury exposure. High-speed evacuation produces better capture when fitted with a cleanup device, which is preferred. Copious amounts of water to reduce heat and a conventional high-speed evacuation device to capture mercury discharges should be used to reduce ambient mercury levels. The amalgam should be sectioned into chunks and removed in as large of pieces as possible using a small diameter carbide drill. Once the removal process is complete, the patient's mouth should be thoroughly flushed with water and then rinsed out with a slurry of charcoal, chlorella, or similar absorbent. During the opening and maintenance of suction traps in operatories or on the main suction unit, dental staff should utilize the appropriate personal protection equipment described earlier. An amalgam separator should be properly installed, utilized, and maintained to collect mercury amalgam waste so that it is not released into the effluent from the dental office. Dentists must comply with federal, state, and local regulations addressing the proper handling, cleaning, and/or disposal of mercury-contaminated components, clothing, equipment, surfaces of the room, and flooring in the dental office. I hope that you'll make the smart choice about your dental care by asking for safety measures during your mercury filling removal. For more information about the Safe Mercury Amalgam Removal Technique, or SMART, including scientific research about why these safety measures are important, visit thesmartchoice.com from the International Academy of Oral Medicine and Toxicology.
The IAOMT spent a lot of time putting that together. You know, anytime you start getting into an area like this, putting stuff out on the internet, there's all kind of potential miscommunications, misunderstandings, legal issues, and all that. And we still have some patients that call in and complain, oh, I went to one of your SMART certified dentists and they didn't do such and such and whatever. And you know, you might have had some of these situations too, like when Kim Chi was talking about the patient had the 4 amalgam removed. I'm wondering, okay, did she go to, you know, that patient go to somebody and have a safe removal technique used? And certainly there's dentists that follow pretty much essentially the protocol that they might not even be a member of the IAOMT and listed on our directory or know anything about SMART certification. So you just have to get to know. If you have a dentist that you are trying to establish a relationship, get to know, you know, ask them some of these questions. And you know, hopefully if they're SMART certified, you can feel a little more confident that they're following the protocol. And if they're not, just talk to them about it, maybe let them know about this and encourage them to, you know, if they don't want to join and get certified, at least if they can go on the internet, you know, it's all out there on the website and they can take it in. And the biggest problem with some of the stuff in here is that the average dentist really has not been trained on some of these special engineering controls. So let me just take a minute and tell you, that protocol was developed, in fact, it's referenced, we have close to 100 references. There's articles and studies that have been done to document the effectiveness of these various methods in the protocol. This is from the NIOSH website, and of course this is the most effective course of controls going down to the least effective. Well, the most effective elimination, duh, you just don't have to deal with it. But again, like I said earlier, amalgam is going to be a legacy product around for decades, even if we were to stop placing it today. Substitution, yeah, okay. That Minamata Convention was encouraging dentists to start using the alternatives, encourage the dental schools to start teaching the alternatives. And those things are all great. The engineering controls, I've got a couple slides that show what those are. And then personal protection equipment, you saw that in the video relative to the masks and the gowns and all. So here's an example of an engineering control. There's this cleanup device. It's kind of a hassle to work with. I can see where a lot of dentists would be resistant to use it. It's like working through a keyhole. And way in the back of the mouth, it gets real interesting trying to visualize what we're trying to get to and drill out. You got to know how to work with it, and that's what the IAOMT tries to do, is train the dentist, become comfortable working with these devices. And the next one here, the problem with this is it's pretty expensive. A couple $1,000, you got to replace the filters. There's special filters that remove the mercury. So this is the part that's parked right next to the patient's chin, and as that pulls in, well, first of all, let me go back to this. Well, let's see here. There we go. The hope is that because of this is a high suction, which probably most of you experience, makes a lot of noise. The hope is that with the water spray and all, that you're minimizing how much of the mercury vapor or particulate that you saw in the clouds and all that and some of the videos, that the vast majority is being captured right here in this area. But that's just not realistic. Can't get 100% of it. So that's why we have this device, the big vacuum. Come on. Right here. So you park that, and that runs at a very high velocity to pull in what escapes that suction right by the tooth. And like I said, it's got the special filters to get the mercury out so that the air that is exhausted from the filtering system has no mercury left in it. So that's a very important thing that all of a sudden, a dentist just getting into this has got to invest a few $1,000s. And that's why this kind of treatment costs more. Patients are always wanting to know, does my insurance cover it? How much does it cost? And all that. Depending on what part of the country you're in, what office, maybe the training and experience of the dentist, that's going to affect the cost factor. Okay, let's see what else we got here. Some pictures. This is in my office. Here I am. I use a positive pressure mask that's hooked to my oxygen tank. It's a lot easier to breathe with. It's cooler. And I've been using that the whole time. Some of my colleagues use the big gas masks that are kind of scary looking and hard to work around, harder to breathe with. This is my assistant over here, the same setup. And the patient is just right down underneath here. Here's that high suction right at the chin. I've got a close-up. That is here. And so here's the dental dam. We find that latex is more penetrable by the mercury vapor than the non-latex. So even though we're so used to saying rubber dam, when we're using it in this context of amalgam removal, it is a non-latex dam, the nitrile gloves. And so here's the dentist, what we like to call the handpiece. Here's the cleanup device, and then we get started. All right, so let's just talk in general about metals. I think I showed this slide yesterday, and right here is where it says there's solid evidence that mercury can induce autoimmune disease both in humans and experimental animals. This has been known for decades, but unfortunately, It just hasn't prevailed in the mainstream consciousness of health providers. And another article here by, this is published about 10 years ago by a Swedish researcher, Dr. Kall, who unfortunately recently passed away. And here we go. The entire article, that's a hot link there, just click on that when you get the slide presentation, and you can read the whole article if you're interested. But basically, the point that she's making is that in metal-sensitive patients, and these are the highlighted areas here, will present various symptoms ranging from oral mucosal changes and skin diseases to excessive fatigue and autoimmune diseases. And here, after nickel, gold is now the second most common sensitizer. And I think I might have mentioned yesterday about ELISA testing. That was her contribution to science, as she developed that test. It's a blood test. Unfortunately, it's not available. It's no longer available in the United States. Some people are trying to find a lab here in the country that will be ready to jump on that and provide that as just one method for testing. Next slide here. Concern, we brought this up yesterday about titanium, and the whole issue there is again, it's another metal because of, there's so much increased exposure to metals these days. Some of our patients have been getting piercings and have no telling what kind of metals in direct contact there. And so more patients are getting hip replacements, knees, all these parts. Now, even in the medical industry, some of that is transitioning to the ceramics, but there's still a lot of titanium use out there. So because of all this interest and attention with metals and autoimmune, I co-authored this article for the IAOMT website with our program director. It's kind of a lengthy document, but it can be obtained here at the website. This is a table, just one little section, that talks about and shows the various metals. We've already talked about some of the materials used, but this is about the dental bridges and crown materials, which will have all kind of different things. We use alloys, mixtures of metals in dentistry a lot, and it's because when you combine them, they will typically then have good, strong physical characteristics, because people want their treatments to last a long time. And that's where all the attention has been going back, decades, is making stuff that lasts a long time, but real no interest in the biocompatibility, or very little. And so all kind of combinations that can contain things. Gold is very common, but there can be nickel, palladium, platinum, silver. There's a number of things that just can be problematic depending on the individual. So where does that leave us? How do we figure out what materials to use? Like we said earlier, some people use muscle testing or electrodermal, various other modalities. There are some blood tests available, and biological dentists usually have some pretty good familiarity with these. And a blood sample is taken, sent to the lab, that then processes it and sees how various antibodies to 94 chemical ingredients, how many occurrences there might be, and then the test results that come back will summarize that. Provides this detailed list of materials that hopefully will be safe to use for that patient. There's two companies that provide this. I don't know if the battery's getting low in this clicker or not, but you might want to check it for the next speaker. But anyway, here's this cover of the report, and since this is just a sample, they left this, but you'll see the various chemicals the person had a positive reaction to, and then the area below that they did not. And come on, there we go. So there's a close-up of a page that shows literally dozens and dozens. I mean, this report is like 100 pages long, and that's just the first part that is by sections, and then they have another part that's basically it's the same materials, it just lists them all alphabetically. So it's a pretty thick report. But if there's an S next to the material, then it's hopefully suitable, most likely suitable. I always tell people, look, nothing's 100%, but this is, you know, one way to check it out. So that's what some people do, and others just hope and pray that whatever we're using, and usually what I've gravitated towards using are materials that I've seen over the decades test out nicely, or companies that have really good track records. So this next slide is an example of a material that I use made by a company called VOCO, V-O-C-O, and the product is called Admira Fusion, and right there. And it's basically silicon oxide. It is a very biocompatible material that uses this Orsimer, which stands for organically modified ceramic technology. And that's a very new technology and a very biocompatible result. So you get into, these are just some of the details off their website, but the big news here, like we said yesterday, no BPA and all these other chemicals that are of some concern. So that's the Admira Fusion, and here is, come on, there we go. It's a light cure material, so when we place it in the tooth, it's soft until we use the light on it, and that starts a chemical reaction to where everything fuses together and provides a very strong bond to the tooth. Oh, jumped over. So we start off with a patient, come on. Here's the amalgam, need to get that out so it's safely removed. And there's the dental dam, they come in different colors. And nice cleaned out tooth, all the decay's been removed. And so we've got a situation in which we can place what we call a direct restoration right into the tooth. It's just fitted into the tooth and adapted and bonded, and there's the finished product. Looks great. And these statistics patients always ask, well, how long is it going to last? I always say, if you're familiar with the bell-shaped curve, you're going to have people, usually the most common reason for failure, they'll crack off another part of the tooth that's been weakened over the years, or they'll get decay around it because they're not flossing, and up underneath here, you know, enough sugar. You saw the theories yesterday, bingo. They've got tooth decay. The fillings may be doing fine. It's just the tooth structure that's failed. So, all right, come on. Crowns, you know, when you get to a point where you've got more filling than tooth, you got to do a crown. And there's always been these porcelain fused to metal crowns for decades now. The metal, there's no mercury used in those, although sometimes there's mercury fillings underneath of them, which can be a great concern. The galvanicity can be a real issue because now you got amalgam fillings sitting up underneath here, and you've got some kind of alloy that's got who knows what, gold, maybe some silver, some palladium, and whatever. And that creates some real interesting galvanic currents. And a lot of times you can't see the metal. This little metal edge, usually it's parked on the inside where it's not visible, like down under the tongue or up on the palate side. But now we've got the all ceramics, and that's this group right here. And very biocompatible materials, generally speaking. There's a few patients that'll, their report will come back, they're reactive, but let me show the next slide. We got a new system here. If you've heard of CAD/CAM technology, it's computer-assisted design, computer-assisted manufacturing. Now, I've had a unit for about 9 years. It was earlier generation that just took still shots. I just upgraded to this new Emerald system, which now does video, and I'm going to show you a sample of that. But the nice thing about this, instead of taking the gooey impression materials that people get gagged on and don't like the taste or whatever, this is what we'd call a digital impression. So here is a 1-minute clip that shows the technology in action. So that gives us then a model. Now that wasn't scanning an area that had been prepped for a crown like we see here, but anyway, so here's the situation. So what the dental staff does then, we take this model and use the software to design the crown material. We hit a button that sends a file to the mill that's right around the corner there in our office. We take this block, this ceramic block, put it in there, hit the button. 15 minutes later, that's drilled out and sculpted that ceramic block into a crown, custom fit for that patient. It then needs to be crystallized, because you see the color there. We don't want it too hard, because otherwise it'd take an hour to mill it here. So what we do, we run it through the oven for about 15, 20 minutes. That gets it to its proper tooth structure color, and then we are able to adjust and cement it. The beauty of this, we can do a same-day crown. No going out to the lab, no temporary. It's a great technology that gives us a lot of advantages. So here we go with a real gray area, just real quickly. I'm going to we're going to have this panel here in a few minutes for the detox. I just want to give a couple slides to kind of get us thinking along those lines about the detox issue. And of course, some people talk about what kind of testing to do. You've already heard about challenge testing. There's a Quicksilver company that offers a tri-test, which is a combination of hair, urine, and blood, all collected at the same time, that the lab is able to interpret the data and give us a little better idea if this person's having retention toxicity issues or not, and what kind of an excreter that they might be. So that's something to consider. The Academy a long time ago approached a bunch of experts and said, hey, can we get you guys to give us some recommendations? You know, what's the ideal detox protocol? Well, they came back months later, said, you know, we just couldn't agree on anything. And that's a real problem. So we kind of pulled back and said, let's use this term biological support and just increase the level of antioxidants, get the person eating well, supplement as necessary, great approach. But for a lot of people, that's just a start, and it's not enough. So then you get into, well, philosophies of detox. I like to use this term blind guessing theoretical, where you just kind of throw a little bit of here and there. Some people are detoxing on their own, or somebody who's been more properly evaluated and worked up and maybe had some testing done, checking on their SNPs and how well they're methylating. That certainly adds the ability to customize the recommendations. For those of you familiar with Chris Shade, he had a recent article in the Townsend Letter, something called push-catch system, which is consistent with some of the stuff like what James has on the BRMI website relative to detox. There's a whole article there that is great, you know, and you talk, you know, you have some similar things going through there. So again, a lot of different ways to skin the cat. Just real quickly, I want to comment, there's, and on Quicksilver, he's got an ebook on this you can download and get some more information. The hot link's right there. And if this clicker, okay. Porphyrin testing, this gives you the ability to identify if a person's pathway of porphyrins leading up to heme and hemoglobin, if they're not, if their pathways aren't working right because of some mercury interference. Are you able to control forward? Yeah, well, I might need you to help with that here in the next couple of slides. Here's just another readout, and again, some areas have been identified as being impacted by mercury. So, person's mercury toxic, you know, you might notice some elevation of these, and that's been borne out in the literature by some folks. Next, thank you. And here's an article. This material is under review. They're trying to get it FDA approved. This fellow is going to be lecturing in the next IAOMT meeting, giving us more information about it. Next. And for those of you who heard Dr. Boyd Haley, he used to have a product on the market that was called OSR, oxidative stress release. And maybe maybe this group can have him come speak sometime, because he's quite an expert on mercury toxicity, and that would be a valuable part of our discussion. just go ahead and zip through those. There's not enough time to get into it. But the information's there. You can look it over. And the FDA is evaluating it. He's already been publishing his work and clinical trials with FDA that just are going to take more time. Hopefully in a couple of years it'll be available. Good thing about his product is that it doesn't take out the good minerals. It just goes for the heavy metals like mercury and lead. So, with that done, are there any questions? Well, she said time's up. I'll tell you what, we're going to have this panel, and if there's any questions, let's just get into it then. So, James, who do you want up here? Thank you.
We thought we'd just brainstorm this a little bit, and with I know that some of you all also have things to offer in this regard, because this is such a new direction of detoxification from amalgam removal, and some people, begin the detoxification prior to the amalgam removal, as well as, of course, post-detoxification after it's removed. There's many different protocols, many different products out there, but I'd just like to say that generally detoxification is a long process, and that some people think, well, I took it for a very short period of time, this certain product, and that's not going to be effective, because as Dr. Kall said, these things get entrenched in deep into the body, into the connective tissues, into the brain structures, and they could take years and years to sometimes really effectively detoxify someone. So generally you want a strategy that will a person can afford and will be compliant with over a long period of time. Would you like to jump in? Because I know you all do it a lot.
That's pretty much what we do. In many years ago, almost 20 years ago in Portland, when I was there, I tried to start a group with dentists and naturopaths to, sort of work together with these patients who were doing this. And the greatest challenge I had was, because what I wanted to do is I wanted 3 months before the person did the dentistry, no matter what the dentistry was. Because that's kind of what I find is a sort of a minimum length of time to try and get their amalgams working half decently efficiently. And the dentist had a great difficulty saying, well, go and see, the naturopath for 3 months and then come back. They said, we'll do the dentistry, then we'll go to the naturopath, which makes it much harder. And I do the same thing with cancer patients. It's like, if I have 3 months before they start any treatment, the success is so much better if you do detox before they basically start any type of cancer treatment. So we do like what everybody else does. We call them basic treatment guidelines. If you're not doing the types of things that I talked about, if you're not sleeping and eating on a regular basis and drinking water and moving your body, which is the first step of any detox, castor oil packs, of course, become an incredibly important aspect. Dry skin brushing becomes essential. Moving your lymphatics, however you move your lymphatics, so whether it's a little mini rebounder or walk 150 minutes a week, and that's before we give anything. So I'm much more interested in them doing something before we give them something, because I have found is if you start giving them things before their systems are sort of warmed up, you're just going to make them more congested and they feel worse. Because I really would say, since I've done drainage for 20 years, I personally have never seen a Herxheimer reaction in a patient if they do this stuff first. If they do it after, they get reactions all the time. So it's the timing becomes the most critical issue, and there's obviously 101 different ways to do it. I personally use endo numbers, which I've been using for 20 plus years, because I think they have the ability to detox anybody of anything over a period of time. So I just feel really comfortable using them. And I do that in compliance with all other different types of therapies in general. So once you get among trees working, and once a person is following, I call it natural laws now, I feel pretty comfortable detoxing anything. And because, when you're taking amalgams out or have amalgams removed, the greatest issue I found, as you know, when somebody is trying to get rid of mercury, if you pull the mercury out of the tissue before their body wants to get rid of it, all you do is redistribute it. It just goes to a different tissue. And it's like, we're no better off. So you do it, however you're doing an analysis. And I still personally like hair analysis, even though it's like, oh, well, hair analysis. 2002, one of my residents at the time did in those days they were still writing thesis at NCNM, and he did it with David Quaig at Doctors Data in Chicago for hair analysis, and he basically did a really great study of looking at not just the heavy metals, and not just looking at a heavy metal screen and saying, oh, you're mercury or lead is high, but how does it relate to all your essential elements? And he created a graph and a scale, and he put numbers to it, and if it's less than 10, you can forget about it. It's like it's not a heavy metal issue. And then 2 years ago in New Hampshire at one of the, where's Angela? I forgot the name of the doc anyway, he said, if you really want to look at heavy metals, measure serum lead. And if serum lead is less than 1, it's not a problem, unless you have kidney problems or something. But generally, it's like a screening. So now I just do serum lead, and it said if serum lead is over 1, you probably have an issue. And without going into he spent almost a whole day explaining why the physiology, that's a good enough screen, as opposed to worrying about should we do, chelation, should we do DMSA or DMPS, those types of things. So I do the simplest things. Serum lead, hair analysis, costs you less than $100. We'll tell you whether or not heavy metals we should go down that road. And I found that to be pretty successful. But in the meantime, I'm still doing all these, natural laws, we say, basic treatment guidelines. That's the approach I've taken. And I think it's been quite successful for people.
Whatever, yeah. Like ditto. So we get a lot of dittos up here. One of the things that I find is because of lifestyle problems, we're always confronted with compliance because of the rush. So if you've got a good enough reputation long enough that you're attracting patients that will take that recommendation of working on it 3 months before, well, a lot of people won't. So I'm often looking for stuff to jumpstart it. And one of the things we heard yesterday about is, and I do not have any affiliation with the company, but the Ion Cleanse foot bath. If you learn how to use that thing, it jumpstarts everything for lymphatic clearance. You've got to have lymphatic clearance working, and the 150 minutes walking certainly would be intelligent. People are trying to get better, and they think that there's no pain with no gain, so they go push themselves harder, and they just make everything worse because they're doing, high output cardiovascular stuff when they should in fact be resting. So you do need to get into that rest cycle, what we talked about yesterday, get the autonomic nervous system to balance. I was already talking about the industrial hemp extracts can, under the right circumstances, give the autonomic tone huge benefits, clear the lymph. I developed a very simple test it's a really simple screening test. It was developed in applied kinesiology just to check status of the lymphatic system. And in that discipline, it was called retrograde lymphatic checking. And you actually put the arms above the head, patient supine. And I've been doing that today, checking some people. You can see very quickly if you cannot hold strength when you're adducting the muscles up here. It is often an indication of congestion of the lymphatic drainage in the upper part of the body. You can then do any procedure and see if it changes that and improves lymphatic clearance. Well, that was when I started doing foot baths in 2002, I didn't know anything about it, but I said I have to figure out a way of monitoring if it's doing anything, because I was going to try and charge patients for it, and I wanted to try and figure out if I could charge them. I had a way of measuring to see if it would do anything. And so right away I took that applied kinesiology test and I adapted it as a lymphatic screening for the foot bath. It's amazing. You can get someone that's never had that, do the lymphatic assessment test, which just takes 20 seconds, stick them in the foot bath, and afterwards redo the test, and it will dramatically change. So it's crazy. So that's one thing that I think is a kickstart to help the lymphatic system. And the other thing that's often overlooked, and that's why I do all the work with mental emotional stuff in the flower essences, is something called defensive chi. It's a very basic concept. When emotional issues like the standard dysfunctional family of the 1950s on, and still going on, well, probably throughout history, but the standard dysfunctional family, when people's space is invaded, or they feel violated, or they feel marginalized, or any number of things that happens to developing little beings, or if they, like in my case, I had to listen to squabbling to the point it made me a social misfit. I simply couldn't stand being around silly people arguing all the time, because there wasn't any reason to be arguing. They were privileged people, and they shouldn't have been doing that. And this poor little kid had to listen to that, so I went off in nature, and that's kind of fed me on my course throughout life. But when you listen to that, your defensive chi is damaged, and pathogenic chi, which is heavy metals, enters deeply into the matrix to places that it should never go. So it's fascinating when you see somebody that's a Qigong master, you can practically give them poison and they don't absorb anything. You know, if you notice, I mean, it's just amazing. So you have to, when you're looking at a person, and that has to do with their constitutional predisposition, the Vata, sthenic body types are much more likely to have less defensive chi. They will be a much harder person to get, well, it will just take much longer, you know, to get that stuff out of that person. So if you can get their mental emotional framework and their spiritual framework stronger, their sense of self stronger, that's a missing element in so many things. So it helps the process. So as far as preparing for the amalgam removal, yeah, I do all that stuff. I just use, you know, different things to check out. But I haven't done a urinary challenge test, and I think you do that, right, often. And I think that'd be a really cool thing. I used to do hair analysis with analytic research labs that started all that stuff in the 70s. I think they were one of the first people in Phoenix or something in Arizona. Did you ever use them? Analytic research labs? Yeah, long time ago. And then I started getting such variable results that they would some patients would come in, I knew they were sick, they had great big problems, and this was for a compliance thing. The patients would look at the results and it didn't show any problem. Then you start working on them a lot, start liberating all the toxic metals, redo the hair analysis in 3 months, and it looked absolutely horrible. And people didn't like that. And you'd have to explain to them, no, it's okay, this stuff's coming out. So anyway, I stopped doing hair analysis, but it's a tremendous tool. But you have to know what's going on. You know, when this stuff shows up, if your patients don't understand it, then they reject your what you're trying to do. But you got to move the lymph and everything else.
So everything that they said. So yes, you know, as far as like not giving things, I find with patients that it's important to get them doing the lifestyle things first so they take them seriously, because we as a society are kind of brainwashed into we need to take something to get better, and if you start them taking something, then they might not want to do the other things or give them as much importance. And for those of you that are practitioners, for myself, I aligned myself with a couple of really good dentists in my area, and I trained them that I'm going to send you patients for amalgam removal, and you're going to do the initial consult and just kind of tell them, but then you're going to send them back to me and you're not going to do the work on them. And so that really worked well. So I had support from the dentistry side, and then I had support with my patients because they knew what was going on, and I learned to tell them pretty much on the first visit if that was going to be an issue, that, you know, they were not allowed to go and just remove their amalgams, because one of the saddest things I'll hear is when a patient would come back in and say, oh, Dr. Stills, guess what? I just removed my amalgams. I know they're bad for me. And I didn't have time to prep them, and they didn't go to the right dentist, and they had them done inefficiently and ineffectively and weren't protected, and now they're going to have an autoimmune issue or something coming up from that. So a lot of it is just about managing it, thinking ahead, planning, and really, you know, navigating the field so that there's protection and that everything's done properly.
I'd like to ask a question just for the rest of the panel, because I've forgotten the name of the dentist, but I think he's passed on now, but he's very famous and did all the Huggins, yeah. So I talked to him when he was still living. I think he has passed on, yeah. Mm-hmm. And it was several years ago, and I asked him about mercury removal, and was saying, should it be done one quadrant at a time when there's a massive amount? And his whole thing, and he spoke to me at some length about it, he said, no, he said, I sedate my patients and take it all out at once. Because the initial exposure, he'll like, if they have that much, he'll schedule a whole 4 hours. So I wanted you to comment on that. His thing was that the exposure massively, they will actually absorb less in the long run than if you did a quadrant at a time over time. So if you could comment on that. That's an important thing for somebody that's got a lot of amalgam.
Well, my initial comment would be, show me the science. That's one of the IAOMT's mantras. And I think my other mic still works.
Okay.
So there's a lot of opinions out there. And, you know, you could argue, yeah, that one bolus of exposure, you're maybe only going to be able to absorb so much of that. But I would submit that it depends on what kind of safety protocols have been applied and how well they've been applied. Now, we don't have the data to show that, you know, a dentist following that protocol that you saw, we don't have like before and after blood testing. There's actually a study done over 20 years ago relative to just the rubber dam only, because some of our members, some of the older members, they don't use rubber dam. And they thought that that cleanup device was going to be good enough. And in fact, that was one reason why IAOMT developed that SMART certification, because we were going to make rubber dam. In fact, it caused some internal political rift within our academy with some of our older members and leaders, and even a founder or two. So we had to work through that. But there's not a lot of data out there. But when you look at what protection is in place that I showed, it is pretty hard to imagine that there's much intake by that patient, and, you know, unless somebody's getting sloppy and they're not fitting the mask on just right, or they're not getting the rubber dam on just, you know, something like that.
But Huggins wouldn't have been using that stuff back in the, I mean, I don't remember, because when I started in the 70s, I don't remember them talking much about that.
Yeah, now,
yeah, but not all the stuff we just saw.
But the question was 4 quadrants.
Yeah. There's a lot of issues there that we could argue about. Yeah. Mike.
Yeah. So that you've got to test electronically to find out which ones need to be taken out first. So
that's another controversy.
That's a whole nother complexity.
Because again, there wasn't published studies to support that.
Right.
It was all anecdotal, and anecdotal has value, I know that, but we just didn't, yeah.
Yeah.
Oh, no, they have not. They will continue. They can leach out for 50 years. Yeah. Well, the question is, how well of an excreter the person is. I mean, there's all these other things to consider. And what's their condition of their terrain and their capacity, and also, yeah. Well, sure. I mean, there's a lot of considerations to make. I'm totally support the whole idea of going slow, thinking it through, not just knee-jerk reaction. Somebody's talked to a friend or heard something, and all of a sudden it's the great panacea. Because most of us do have those initial consultations, and we're trying to tamp down the patient's expectations a lot of times. And we're trying to, if they haven't had opportunity to have the full workup with a medical provider, we encourage that. Unfortunately, sometimes that's not easily available, or the patient says they can't afford it or whatever, but that's a huge issue.
I mean, I think it comes down to the fact that this is individualized medicine, and that all of us, we are all overwhelmed because there are so many individuals out there that need help on all different levels. But on the other side of that, we are hanging together and going one step at a time. But I think you can't really decide until you look at the patient. And so I've had a couple of different thoughts. I'm going to jump down. There's some very good studies on apple pectin as a So one of the issues, if you're going to do some sort of gentle chelation, and of course you need to do overall detoxification, but if we're focusing on heavy metals, mercury is incredibly insidious. And when I listen to this lecture again for the lots of times, like 50th times, it's unbelievable the problem that we have with these heavy metals in our environment, and really mostly since the 1950s. And so I have to kind of get over that again before, because this is really an emergency, but we can't, it's all an emergency, so I feel like I have to sort of take it one step at a time. But don't ever let somebody think that their mercury is fine in there. It's a very, very, very neurological immunologic toxin, and every pregnant woman that has a mercury filling shares or dumps mercury into the cord. You know, they've done cord blood studies on newborns since probably the 70s, and their mercury is 3 times as high, at least, as the mother. So that said, what you want to do is make yourself as very much healthy as you can. But, you know, and just keep at all of this. I don't think there's any right way to do it. That is the only right way. But back to the chelators, everybody understands that if the mercury settles into the tissue and into the connective tissue in the brain, that you have to just, there's all sorts of controversy about how you get it to come out of the double bonded sulfur bonds that it's in the tissue with and then be excreted. So that's what a chelator is, and there's a whole bunch of different effects of chelation. But one of the things that I was reading about is that apopectin for small children is a really good chelator, and there's some very good research on that. I'm always looking for a way of chelating people that's going to work that isn't toxic like isn't potentially toxic like some of the other agents. So that was just another pearl. And you do it over time, and it, you know, maybe all it does is keep the kid pooping, because I've got to say the number 1, the number 2 detox methods we have are pooping and peeing, and we need to do that lots of times every day. So, you know, don't take that for granted. Anyway, thoughts come and come and come. But we do, we forget. You know, we go into these great protocols, like Dr. Tom was saying, but let's just do the basics. And the lifestyle for every single one of us in the whole room is important. So here we are together.
Our time's up.
Yes,
Yeah.
okay, lunch.